Hello, my name is Greg Johnson, Medical Science Liaison for Neurelis. I really appreciate the opportunity to present to the Epilepsy Foundation of New England audience today. I am a former neurophysiology researcher at the University of Vermont and Beth Israel Deaconess Medical Center in Boston. I received my degrees from the University of Vermont and Williams College in Massachusetts, and I have been a proud New England resident for nearly 15 years now. I'll be speaking today about seizure clusters, rescue therapies, and acute seizure action plans. And I must point out, as just a quick disclaimer, that this presentation is for informational purposes only and does not constitute medical advice, nor is it intended to replace discussions with a healthcare provider. Here's just a quick agenda for the presentation today. We're going to discuss the prevalence and burden of seizure clusters, the various vocabulary around clusters and how they present, that these types of events should be considered a medical emergency, the types of treatments available to treat that medical emergency, and then the importance of seizure action plans. So let's just take a quick step back for a moment from seizure clusters and just broadly talk about epilepsy for a moment. So epilepsy is characterized as an enduring predisposition to seizures. Rarely, or maybe not so commonly, a diagnosis of epilepsy is made after a single seizure because there's often not clear anatomical or physiological evidence of neural dysfunction. But once those few seizures have occurred, then diagnoses are more frequent. Epilepsy affects around 3.5 million people in the United States currently, of which around 500,000 are children. Epilepsy is kind of interesting in that it has a bimodal distribution across age groups, with a higher prevalence in children and the elderly, with relatively less in the middle-aged population. And as much as 40% of patients are considered refractory, and that's to say that they have seizures despite the use of anti-seizure medications. So of that 3.5 million person prevalence, an estimated 5% or so experience seizure clusters, which would equal a prevalence of about 170,000 patients at any one time in the United States who experience clusters. Now, seizure clusters have gone by a few different names over the years. Acute repetitive seizures, bouts of increased seizure activity, seizure flurries, crescendo seizures. All of these things mean pretty much the same thing. And that is to address that these seizures can occur in these groups, and they might occur more frequently within those groups in some patients. Now, one thing to address is that clusters are not a type of seizure, so they're not analogous to something like a generalized tonic-clonic seizure or a partial seizure, also called a focal seizure, or an absence seizure. Clusters describes the way in which any of those types of seizures present, and that is with some unique relationship in time. Defining these episodes is sometimes a little bit difficult because there is both between patient heterogeneity and within patient heterogeneity in how they present in frequency and description. So what I mean by that is that one person might experience clusters differently than another person, but that same person might also experience clusters differently as time goes on. So it's hard to get a mathematical definition nailed down, but the way many patients and caregivers describe their experience just kind of avoids the math and statistics and simply says, I know it when I see it. So in an attempt to at least capture all seizure clusters in one sort of operational definition, one recent proposal was that 2 or more seizures in a 24-hour period can be deemed a seizure cluster. But you can likely see the problem even with that definition, as some people with epilepsy experience more than 2 seizures a day, almost every day, but those aren't quite clusters. Those are just really high frequency of seizure activity. So it's an abnormally high frequency of seizure activity that we're talking about. Now, with any other seizure pattern, clusters can be triggered by an environmental stimuli. The classic flashing lights as a seizure trigger is certainly possible, but really by far the most common trigger is missed medication or erratic scheduling of medication, such that the amount of medication in the blood of a patient at any one time is variable when we're trying to keep that actually fairly constant. So that's kind of an arguable point as a trigger when it's really kind of just removing the brake on seizures. But the point remains that seizures can be unleashed by missed medication. And then there's this other idea that sort of stands in a little bit in opposition to the flashing lights, which are a very short and punctate stimuli or stimulus. And that is that stimuli that seem to trigger the most seizures are usually the longer lasting stimuli. Things like stress or lack of sleep or nutritional deficiencies, alcohol, recreational drugs, all of these things that provide a change to the body's homeostasis that is lasting on the order of minutes, hours, days, more like hours and days, has the higher probability of causing a seizure. Now we think of seizure clusters as a seizure emergency, and as such necessitate treatment with a sense of urgency. Most seizures, of course, even breakthrough seizures, tend to be these isolated and self-limiting events. Clusters, on the other hand, tend to be less self-limiting and have the potential, like any seizure, theoretically, to progress to a prolonged seizure or status epilepticus. Research does show that patients who experience clusters are at a significantly higher risk of experiencing status compared to patients who do not cluster. And of course, there's a little bit of a confound in that relationship, because if you experience seizure clusters, that kind of just means that you experience a lot more seizures. And if a lot of seizures have the theoretical potential to progress to status, then you would expect that someone with more seizures would progress to status more frequently. But there might actually be some kind of a relationship between clusters and status that is currently unresolved and not explained by just seizure frequency, but it's currently an area of research. So we often think of seizure clusters as being this sort of short-lived event, but evidence shows that's actually not really the case. So if we were to start the clock on the start of the first seizure of a cluster episode, the most follow-on seizures would actually fall into the 6 to 12 hour window. So it's really a tricky condition to treat, because you need a therapy that works fast to treat the initial seizure, but also provides coverage through that whole window where the most follow-on seizures tend to occur. So we're talking about, if this first seizure is at 8 a.m. in the morning, then the highest, most likely time in the rest of the day where another seizure is going to occur is between 2 p.m. and 8 p.m. of that same day. So it's really quite tricky, and treating it effectively can be quite tricky to prevent recurrence. So as you might imagine, experiencing clusters with any real regularity is pretty disruptive to life and quality of life. And that's most likely due to the anxiety that it causes. So for anyone who ever experiences some kind of a prodromal event or an aura that precedes a seizure, or even if not a seizure, but an aura that precedes a migraine headache, imagine sort of the anxiety that you know that something bad is about to happen. But clusters, in a weird way, are kind of like that, where you know something bad is about to happen, but the signal that something bad is about to happen is a seizure itself. So the prodromal period is a seizure. So then you have the stress of the one seizure, which, leaving aside the medical emergency that the first seizure is, but then you know that that's signaling that more seizures are going to succeed that one. So you can imagine how that knowledge could be pretty anxiety inducing and pretty disruptive to quality of life. And this quality of life data is borne out in patient surveys. So here we see some of the metrics of how much seizure clusters impact quality of life, and it's fairly striking. So over 50% of patients and caregivers report that seizure clusters negatively affect ability to drive, mood and affect, career, social life, and more. And so that's, of course, like kind of the more intangible, more difficult to measure statistics, but there are also the more highly tangible and more easily measurable consequences, such as ER visits, injuries to the body from falls, and injuries to the brain from the metabolic insult of a seizure. There's the old adage that time is brain. So the more time spent seizing is the more damage that is potentially being set upon the brain. There's another idea that still has some validity, and that's the idea that seizures beget more seizures. So clusters where you're having multiple seizures in just one day or over a few days might actually be training the brain to sort of be prone to further seizures, leading to decreased seizure control. And lastly, and this is due largely to the relationship with status epilepticus, those who experience clusters have a higher mortality rate than epilepsy patients who do not experience clusters. Surprisingly, despite all of these negative consequences, the use of an additional rescue medication to treat clusters is actually quite low. A recent paper reported that 80% of patients and caregivers report not using a rescue medication to treat cluster episodes. And 31% of patients and 40% of caregivers report using an ER in the case of a cluster episode in the 12 months preceding the survey. So it's not that they don't think it's an emergency, because there's still a certain high percentage that's using emergency services. It's just that they're not familiar with emergency rescue medications for at-home use. And if you're thinking about how quickly emergency services can be utilized, there are some hard numbers for comparison on that. So rescue meds are typically recommended to be administered 3 or 5 or 10 minutes into an episode. But if you were to call emergency services, the average time to treatment is around 40 minutes, and the average time to hospital arrival is around 56 minutes. So really quite late in the game when keeping in mind the old adage that time is brain. Which means that we have a situation where there are more people using the ER instead of a prescribed rescue medication. And that's really just not ideal, considering the cost of an ER and the delay between seizure onset and treatment initiation. It's also not ideal because there's pathophysiological evidence that pretty overwhelmingly supports the fact that treating seizure episodes earlier imparts a higher probability of success, and that is terminating the actual episode. There is good news, though, and that is that rescue medication use is associated with more positive outcomes. One study compared a group of patients who underutilized their rescue med to a group that appropriately utilized their prescribed rescue med, and found that the utilizers had a significantly lower probability of progressing to status epilepticus, lower probability of visiting an ER, and a lower probability of requiring hospitalization over the time period that the survey was conducted. So what do rescue medications look like? The standby for decades now has been the only specifically approved product, and that was diazepam rectal gel. This has obvious objections, both from patients and caregivers, especially adult patients. And its adoption was never to its full potential, because most likely because it has to be administered in the rectum, as it's a large amount of volume that needs to be given to the patient. The other options available were off-label use of medications. So there's tablets that you can take maybe between seizures, or some people would crush them up and put them in the lips of patients and hope that some of it was absorbed through the mouth mucous membrane. And then there's some maybe dissolvable wafers that were trying to do the same thing. And then there was sort of IV and intramuscular medications. And those, while very effective, require a trained medical personnel to administer. But now there are actually 2 approved rescue medications that are nasal formulations, that are just a nasal spray. And those may offer a good opportunity to address many of the challenges that we've discussed of the sort of older medications that were always available. So what are the characteristics of an ideal rescue medication? Of course, we'd hope that it would be potent and highly efficacious. We would hope that it would work quickly. We would also hope that, remember, that clusters tend to occur with many of the actual individual seizures occurring in that 6 to 12 time window. So we don't want a drug that is, working really, really quickly and then out of the system really quickly within, minutes. We'd really want something that's more of an intermediate duration of action to treat an episode that is of intermediate duration of action, really kind of on that many hours to maybe even a day or two time scale. Of course, this rescue med should have a minimal amount of adverse events or toxicity associated with it. It should be easy to use, and it should have dosing for both adults and children. So benzodiazepines are the class of drug that most closely matches that product profile I just mentioned. And they are the first-line treatment for seizure emergencies, and that's pretty well adopted. So benzodiazepines work by actually amplifying the brain's own inhibitory transmission. So they do this by making GABA, which is one of the brain's inhibitory neurotransmitters, bind more effectively to its receptor than it does under baseline conditions. So it's actually kind of weird. You would think that it would fit perfectly under baseline conditions, but it's actually the case that adding a benzodiazepine, it will actually bind to the GABA receptor and cause the GABA receptor to fit itself even more nicely into GABA when GABA comes to actually bind to it. And that would actually is what activates the receptor. So there are 3 different benzodiazepine formulations available for rescue. Midazolam is available as a nasal spray, and then diazepam is available both as a rectal gel and as a nasal spray. So of course, up until recently, there was only the one FDA-approved choice for rescue, diazepam rectal gel. But now that there are 2 intranasally administered products available, it is important that patients' healthcare providers discuss rescue medication options, help develop a seizure action plan, and understand the specific needs of each patient and their caregivers. Use of seizure action plans really, really helps. It really improves the patient and caregiver understanding on how to treat seizure emergencies simply by getting everyone on the same page. It corrects misperceptions and misunderstandings that could either make the caregiver make incorrect decisions or simply slow the correct decisions from being made. And if there's a child at school situation, which is the case with most children, it will provide the properly delegated caregiver the confidence to utilize a rescue med if that is deemed appropriate. These plans provide personalized support, tell you what to do and when, and can be a critical resource for caregivers to act appropriately in a stressful situation. The evidence is really pretty clear. The use of seizure action plans improves patient and caregiver understanding on how to treat seizure emergencies. It gives confidence to the institutions that a child is well prepared. And this may really help for things like field trips or other out-of-school activities that kids want to participate in, and that it gives the supervisor confidence that the kid can do that safely. And then, at the end of a seizure action plan, it has information on what should happen if the situation worsens. Should EMS be called, or should a rescue medication be used? So this is just an example of a seizure action plan provided by the Epilepsy Foundation. And as you can see, it gives space for you to fill in your physician, school nurse, or other healthcare provider. Has space for patient information, seizure information, how a seizure looks in that particular patient, because we all know that seizures look a lot of times different from patient to patient. It has a response plan, appropriate first aid, and when to use a rescue medication if that is part of the plan. And then on page 2, it provides space for proper care when the seizure has been terminated. So a lot of times people with epilepsy will wake up sleepy or just confused. So having individualized instructions for how to care for when the seizure's been terminated is important. And then there's information for emergency medical services if it's needed, including what kind of an anti-seizure medication the patient's on in the first place. And that's really important to know for potential drug-drug interactions if the patient needed to go to the hospital. And then there's a space for known triggers and the patient's physician information to let them know that an event has occurred. So these plans are most effective when they are up to date, of course, and best reviewed on a yearly basis, especially with children in school. It just makes sense to review them over the summer with the school nurse. And the other thing is that epilepsy in student-aged people is more variable than sort of adults when it's kind of settled into a normal rhythm. So, children who are rapidly growing, their seizure patterns can change on a year-to-year basis. So it really requires a little bit more frequent updating. Adults probably not quite as frequent and maybe not quite yearly, but still should be updated on a regular basis. So in summary, seizure clusters are a type of seizure emergency and require immediate attention, as early treatment is really critical to treating effectively. Rescue medications should be discussed with your physician to determine who is an appropriate candidate for their use. The best handled cases are ones with active collaboration between the patient, caregiver, physician, and community healthcare providers, such as school nurses. And seizure action plans are really a critical piece to ensuring that the right care is provided at the right time by the right person. So with that, I will thank you very much, and I believe we'll have some time for questions. Thank you.